The new lipid guidelines do not use the ATP3 risk estimators. Instead, there's a whole new ASCVD risk calculator is what it's called. The new tool developed by the ACC-AHA Risk Assessment Work Group. It's actually officially called the Pooled Cohort Equations to Estimate 10-Year ASCVD Risk, and I appreciate them abbreviating it to just the ASCVD risk estimator. This is a new paper in the September 5th issue of JACC that we're talking about, and it is a systematic examination of the 2013 Pooled Cohort Risk Assessment Test for atherosclerotic cardiovascular disease. And I'm with the author of the editorial comment that goes with this. Primary prevention of atherosclerosis, and particularly bringing clinicians and patients to the starting line, which is wildly important. Michael Farkouh is an MD, director of the Heart and Stroke part of the Luer Center, and he is a cardiologist at the Peter Munk Cardiac Centre, also at the University of Toronto. Now, when this first came out, the new lipid guidelines, it was somewhat controversial, and particularly a lot of controversy surrounding the risk estimator. Yeah. Can you give us an idea of just why was there controversy?
Well, I think that the point of the matter here is that for any risk tool, there will always be criticism. When you try to validate it, it comes from many different models, from observational studies, from randomized trials, from looking at traditional risk factors to looking at important biomarkers like CRP, calcium scores, and all of that. So there was I think in the community, a worry that we were overestimating risk of some of these folks, so that we were going to have, a substantial proportion of our population on statins in the next 10 to 20 years if we follow the new risk calculator. Concurrent to the release of, and there were many, many arguments on both sides, there's been a lot of discussion about this, I think it's only important to note that when we look at regards and some of the studies that came from Paul Muntner's group concurrent to the publication of the guidelines, it looks like it performs very well in a more broad population. A lot of the studies we've done, like Framingham, are in patients who are primarily white and primarily middle class. And the idea here in this particular guideline and with this risk tool was to look at whether it really applied to those who are African Americans, who have been understudied, those who are Hispanic, and those with diabetes, who have not been studied in some of these guidelines as well. With the assumption that everyone with diabetes should be treated aggressively. Exactly. But in fact, what about a young diabetic who's 44 years old, and where do they fit in? So the whole idea of this exercise was really try to see where does this risk calculator come in, and how do different people meet the threshold, and at what age do they meet the threshold to be treated with more aggressive therapy.
What did they find in general?
Well, what they found was in fact that across the board that they found that for with the important variables of age, ethnic groups, and diabetes, they saw differences in important trends as to when people would need to be started on statins, which made a lot of sense. So they feel that this particular tool now can be used to educate people about getting to the starting line, which is what I talked about in my editorial, which is the fact that we're just presenting to them what their risk is at a certain point in time, and we think that the risk tool takes into account all the different permutations and combinations that we can see in our practice and in American practice with regards to age and ethnic groups and so on.
In your paper, you state that in your conclusions, the paper highlights the importance of the clinician-patient discussion prior to initiating statin therapy.
Yes.
You got to have that conversation.
You have to. I think if we assume that everyone that meets, for example, in the guideline, it's stated that if you have an annual risk of 7.5% of having a major cardiovascular event, that's the threshold upon which someone should be recommended for therapy. But of course, for some people, if you have a very strong family history and you're at 5%, you might say, hey doc, maybe I should start this. My dad had an MI when he was 48.
Exactly. Let's try a statin.
Right.
Huh?
And the same as in a population, maybe in countries with national health care in which they don't have the resources to treat everyone, they might set that bar higher. So the idea is it brings to mind individual care, the patient's individual risk and their knowledge of their risk. And they are really the determinant of whether they're treated or not, right? This is primary prevention. And I think that we should not be so arrogant as physicians to say, well, I know when someone needs to be treated. I think people need to be part of that discussion. And we don't have all the evidence.
So based on this paper, the new risk calculator, do you have confidence in it? More confidence? Less confidence?
Yeah,
we still have a lot of questions.
You know, for me, it's been validated by some very good scientists. It started a discussion. It allows me to inform my patients about their risk. And I think it's a great starting point. Do I think it can be refined? Absolutely. Do I think there'll be new biomarkers and new imaging types of studies and blood markers that we can use to help inform us? That certainly will happen with time. But I think we're at a point now where we need to educate our patients. We are under-treating our patients because they're not well informed and because they're also very afraid of the side effects, which also have to be part of the equation. Right. And like the new onset diabetes, we need to inform them that these people that have new onset diabetes are going to have diabetes anyways. It's just how much sooner do they get to have diabetes. So that starting line is on many fronts, but I think we need to educate our patients fully.
Well, this is a pair of papers that I highly recommend because the editorial comment combined with the look at the estimator, I think this gives us some answers to some of the questions that were raised when the guidelines were released. For Cardiol Source World News, I'm Executive Editor Rick McGuire.